Hello everyone and welcome to today's webinar hosted by WR Medical Electronics in collaboration with Dr. Wolfgang Singer and Mr. David Sletten of the Mayo Clinic in Rochester, Minnesota. Before we get started, I would like to do a brief overview of our agenda and go over a few details of the platforms that you get the most out of this session. To begin, we'll introduce Dr. Singer, who will be taking us through an in-depth look at the role of Qsart testing. Then, we'll move into a brief video of a pre-recorded Qsart test done by David Sletten at the Mayo Clinic, where he explains the technical process of testing step by step. After the video concludes, we'll be having a Q&A session with both of our guest speakers. We'll do our best to get through all the questions, however, some questions may require a follow-up offline. On that note, if you would like to have a question answered, please use the Questions tab on the right side of your screen. If you do not see that sidebar, there is an option on the bottom right of the screen to show/hide that element. You may also see a prompt to answer a poll, in which case we'd greatly appreciate your feedback. If you have any technical issues, please use that chat function and we'll do our best to assist you. Most problems can be resolved by simply refreshing the page. I would like to thank you all for attending and we hope that you enjoyed today's session. Without further ado, please allow me to introduce Dr. Wolfgang Singer.
Hello, my name is Wolfgang Singer. I'm an autonomic neurologist at Mayo Clinic in Rochester, Minnesota, and head of Mayo's Autonomic Laboratories. It is my pleasure to welcome you to a brief webinar on quantitative pseudomotor axon reflex testing as one important component of clinical autonomic function testing. We will cover the role of Qsart as part of a standardized testing battery for autonomic dysfunction. We'll briefly cover the underlying physiology, testing principles, and a few clinical examples before focusing on how the test is done in the lab with a full demonstration. The demonstration will be done by David Sletten, who is a principal autonomic technologist at this institution, who was involved with developing the current technology used for Qsart and has many years of experience in autonomic function testing. The goals of autonomic function testing are to detect the presence of autonomic failure, to quantify the severity of deficits, to determine the distribution of autonomic failure, and to detect the site of the autonomic lesion. Important attributes of an autonomic function test are for it to be sensitive and specific, to be reproducible, to be clinically relevant and have a physiological basis, and ideally to be non-invasive and practical, with available equipment and support to do the test on a routine clinical basis. And the test should also have confounders that are known and can be avoided or considered in the interpretation of test results. Based on these attributes, a battery of autonomic function tests has been developed and extensively validated over 30 years ago at this institution. It is called the autonomic reflex screen and has since become the gold standard of modern clinical standardized autonomic function testing. It's performed virtually unaltered at the present time, and at Mayo Clinic Rochester alone, we perform over 4,000 of these tests per year. And that same battery has been adopted into commercially available equipment and software that allows for the standardized evaluation of sweat or pseudomotor, cardiovagal, and cardiovascular adrenergic function. We perform Qsart to assess pseudomotor function, deep breathing and Valsalva maneuver to assess cardiovagal function, and we perform a head-up tilt table test which, along with blood pressure responses to the Valsalva maneuver, provides information about cardiovascular adrenergic function. The core principle of the Qsart is quantifying an axon reflex response that is induced by stimulating cholinergic receptors at the level of the sweat gland. This induces an action potential that spreads from the stimulated nerve terminal to neighboring nerve terminals in a retrograde and then anterograde fashion via axon branch points. The induced indirect sweat response at neighboring sweat glands is what we're interested in. In order to not also detect a direct sweat response from the stimulated gland itself, a so-called multi-compartmental sweat capsule is used, as shown here. That capsule has an outer stimulation compartment and an inner measurement or recording compartment, and those compartments are physically separated to ensure recording of only the axon reflex-mediated indirect sweat response. The stimulation is done using 10% acetylcholine solution that is iontophoresed to the level of the sweat glands using constant current at 5 milliamps for 5 minutes. The resulting indirect sweat response is recorded during those 5 minutes of iontophoresis and an additional 5 minutes after that. Qsart is routinely done at 4 standardized sites, namely the volar forearm, the lateral proximal leg, the medial distal leg, and the dorsum of the foot. Responses are integrated over a 10-minute period, and the resulting value reflects the magnitude of the induced sweat response, which requires intact postganglionic sympathetic pseudomotor fibers. Normative values have been generated based on recordings in almost 500 normal subjects. Qsart is of greatest value as part of the full autonomic function testing battery, but is particularly helpful in detecting distal small fiber neuropathies, as shown here in this example where the most distal response at the foot is essentially absent. It is also helpful in quantifying the degree of small fiber involvement in peripheral neuropathies in general, where more widespread abnormalities may be seen, often in a length-dependent pattern. Vastly abnormal responses are seen in conditions that result in widespread autonomic failure. In the example shown here, the patient has autoimmune autonomic ganglionopathy with clinically global anhidrosis and absent sweat responses on Qsart at all sites. Apart from Qsart, there are several other techniques that have been used to assess pseudomotor function. These generally either do not directly assess pseudomotor fiber function, are less sensitive for specific, or are less practical for routine clinical use. An exception is the thermoregulatory sweat test, which assesses pseudomotor function over the entire anterior body surface using a sweat chamber to raise body temperature and visualizes sweating using an indicator powder. The TST assesses not only the postganglionic axon, but the entire pseudomotor pathway from hypothalamus to the sweat gland and can be particularly helpful in differentiating central from peripheral lesions. Unfortunately, the test is time and labor intensive and therefore used only at selected autonomic centers. Here's an example of the combined value of Qsart and thermoregulatory sweat test in a patient with Parkinsonism. The preserved Qsart in areas of complete thermoregulatory anhidrosis suggests a central lesion and is quite characteristic for multiple system atrophy. When interpreting Qsart results, it is important to keep in mind factors other than disease that can affect test results. For example, gender is an important variable as sweat volumes in women are typically markedly lower compared to men. Proper skin preparation is also very important and will also be emphasized during the testing demonstration. In a study, we could show that absent responses can be the result of imperfect testing preparation, as shown in a graph on the right. Also, many medications are known to affect sweating, and proper instruction on holding potentially offending medications prior to testing can help avoid spuriously abnormal results. At our institution, patients receive standardized instructions prior to testing that emphasize the need to hold certain medications if felt safe to do so, but also instruct patients to avoid alcohol, vigorous exercise, caffeine, and nicotine prior to testing. Ordering physicians are instructed to follow practical guidelines on holding certain medication classes that are known to affect autonomic function testing. I want to close this introduction to the seminar with another example of a patient who underwent autonomic testing showing absent sweat responses at all sites, and upon retesting 4 months later had complete normalization of responses. Now, this was not the result of successful treatment of autonomic failure, the result of coming off of medications known to affect pseudomotor function. And with that, I pass the microphone to David, who will guide you through a demonstration of Qsart testing.
To make the Qsart test more efficient, the technician prepares the testing supplies prior to the patient's arrival. When the patient arrives, a brief interview is conducted where the technician will ask the patient about medication use, side most affected, and if a nerve block or biopsy was ever performed. The patient's skin is then cleaned using acetone, alcohol, and water, followed by thoroughly drying the patient's skin. A machine baseline recorded is obtained before attaching the capsule and electrode assemblies to the patient's skin. The capsule and electrode assemblies are placed on the patient's skin in the appropriate locations. These locations include the forearm, proximal leg, distal leg, and foot locations. Return electrodes are placed on the patient's skin within 6 inches of the capsule and electrode assemblies. Lead wires are attached from the electrodes to the constant current stimulator. Syringes filled with 10% acetylcholine solution are attached to the meridian electrodes. Filling from the bottom luer fitting ensures enough acetylcholine is added and proper current is being delivered. A mark is made in the acquisition software prior to filling the electrode chamber with acetylcholine. Filling the electrode chambers should be done slowly to ensure no acetylcholine leaks into the recording chambers. The constant current stimulators are set to deliver 2 milliamps of current for 5 minutes. When the stimulators are started, a second mark is made in the acquisition software. During this time-lapse recording, you will see additional marks placed at the end of the 5 minutes of stimulation and again 5 minutes later at the end of the test. Once the data has been saved, the lead wires and capsule assemblies are disconnected from the patient, taking care to keep any acetylcholine solution from being spilled into the recording chamber of the capsules. Lastly, return electrodes are removed and the patient's skin is wiped dry. Analysis of the data is completed by a trained professional who will calculate both the response volume and latency. These values are then compared to normal values, and an interpretation is provided to the referring physician.
Thank you, Dr. Singer and David, for preparing those very useful and informative presentations. Now, we'll move into the Q&A portion of our webinar where Dr. Singer will be fielding and answering your questions. So, I'll hand over the controls to Dr. Singer so that we can begin. Thank you.
All right. I hope everyone can hear me. I'm going into the questions tab and read those questions that have come in and are still coming in, and try to address those to the best of my abilities. So the first question is about Qsart and pseudoscan, and the question if those tests are comparable. Well, both are looking at sweat function, so they are comparable from that standpoint. Pseudoscan, however, does not assess directly the function of autonomic fibers. Basically, it tests the intactness of the sweat gland. And so while indirectly the fact that sweat can be produced and measured does measure in a way indirectly autonomic function, it is not an autonomic function test and can maybe function as a screening tool in some indications, but is not really a autonomic function test as such. So that's where the difference comes in. Another question is about the difference between Qsart and Qsweat normative values. So there is a difference, yes. Qsweat is a device that is produced by WR Medical. Qsart is really the technique, but it was originally referred to as such as the equipment that was developed at Mayo and homebrewed equipment. So the equipment is different. There are certain technical differences between the devices that measure sweat function, such as a different gas that is used to evaporate the humidity in the capsule, and that results in differences in the values. And we've done some studies looking at conversion factors between those two different techniques, and such conversion factors have been published, but they're imperfect, which really required us to do a large new creation of normative values specifically for Qsart, and those have been published in abstract form and are eventually going to be published as a manuscript as well, hopefully later this or early next year. There's also a question about the availability of pediatric normative values. We have done a substantial number of children in terms of normative values. Those are still being analyzed. They are not available or published yet. Then there was a question, that was an interesting one, about chronic use of medications that could alter sweating. And if someone is on a medication that could suppress sweating and they come off of that medication for testing, if that could falsely reduce or increase the sweat response as a result, let's say if a patient was more anxious during the testing than they normally are on their medication. So the problem here is that when we take patients off medications, really it's a compromise. It is never perfect because we do know medications, if they suppress or activate sweating, will have prolonged effects beyond just the pharmacologic effect of the drug. So if you chronically suppress sweat production and likely sweat glands atrophy, and you will have reduced responses even if the patient is completely off those drugs. I'm less concerned about an over estimation of sweat responses because we are not really looking at spontaneous sweat production, but acetylcholine-induced sweat production. So we look at an induced response and can differentiate what is a baseline sweat rate and what is the induced response. And therefore, someone who is overly anxious, let's say during the test, can still have a viable test result by just integrating the induced sweat response. There's a question about skin temperature before Qsart. David, you want to answer that? Does not look like David has access, so I will answer that. We shoot for temperature similar to what we shoot for with EMG. So a temperature of, oh, he's running.
Oh, go ahead. You can finish up, Dr. Singer.
No, go ahead. Go ahead, David.
I was going to say, typically when we assess foot temperature, we're looking at 31 to 33 degrees C. Though we have done some studies showing that you could go a little bit lower than that, but from a practical standpoint, 31 to 33 should be utilized. Anything much more above 33.5, you start to see some spontaneous sweating.
David, there's another technical one about electrode placement at each of the 3 sites.
Oh, yeah, so the return electrodes, there should be 1 for each of the sites, so there's a total of 4 per test. And those are only available from WR Medical that I'm aware of.
Then there's a question about practical tips for placement of the capsule on the foot and getting a good seal.
That really just comes with a lot of experience, and a lot of what we've done in-house here is using water in syringes and getting some volunteers and getting people just to keep trying over and over again until they can find that best spot. Sometimes you're not able to go over the EDB muscle like is stated in the literature, and we just have to use the flattest surface of the foot and be sure that we're getting a nice tight seal. We also use something called the down and around technique when placing the capsules, which helps to ensure that we are getting a good seal on that meridian electrode to the skin.
Then I see a question about how to avoid variability in study results. What kind of factors can impact results in room temperature? So yes, you want to standardize testing as much as possible. You You want a standardized setup, control temperature, control humidity, and of course, patient preparation should be similar in terms of medication discontinuation, but then also factors such as nicotine, alcohol intake, physical exercise. All those things should be controlled for, and we have standardized instructions that patients are provided with. So when they come return for follow-up testing, the conditions are as much as possible comparable. And there's a question where one can order electrodes for Qsart except for WR. I think that's a no-no here. You can't answer that. But apart from that, we purchase from WR, and I'm not aware of alternative sources. Let's see. Then there's a question. I usually calculate the half-life of a medication to know how long a patient should hold. Is that appropriate, or is there a standardized list of medications and hold times? That's a difficult question. We do exactly the same thing for research purposes. So where we really review every medication that has a potential of impacting testing, and then discontinue medication for at least 4 half-lives prior to testing. That's the perfect way of doing it. However, it's very time-consuming and not feasible for many applications. For example, a busy clinical lab, we study over 20 patients a day. It would really be almost impossible, very impractical. So for that purpose, we have standardized instructions for our physicians that order testing that tells them the medication classes that should be held for at least 48 hours and medication classes that should be held for at least 24 hours prior to testing, which is a compromise. It's never ideal, but it's a practical compromise that has worked reasonably well. Let us see here. How does Mariana affect Qsart? We don't know. It's a very good question. It's not been formally studied to my knowledge, but in theory, there would be an effect expected. And what makes it very difficult is that some of the metabolites are extremely long in half-life. We would have to take patients off like a month or two before in order to get completely clean testing. But that is a limitation that we really don't know what specific effects they are. David, then there's a question about acetylcholine powder to make the 10% solution.
Yeah, and I think the best is I will put my email as an answer in there for anybody who has questions on acetylcholine, and they can contact me directly. But because each facility is so different in requirements, it's best to keep that discussion offline at this time.
Then there are a couple technical questions in terms of analyzing Qsart or Qsvet. One regarding the value or meaning of latency, and the other one of a persistent sweat response, the so-called hung-up response that's been referred to in the past. While in the early days, there was some emphasis on latency and on the configuration of the response, we have progressively gone away from that as these factors are much more variable than the actual sweat volume, and there can be quite a bit of variability even in normal controls, and by repeating the test from one day to the other. So we have really gone away from putting any emphasis on latency or the configuration of the response. So a persistent sweat response or an increased latency, we would not focus on in our interpretation. Although some antidepressants have very characteristic effects in that they not only reduce sweat volume, but also significantly prolong the latency, and that can be a clue that there are still lingering medication effects. Let's see here. Oh yeah, so there's a question about, normally we focus on reduced sweat responses, and if Qsart has a role in assessing excessive sweating, particularly in focal dysfunction. So that's a difficult question. I don't think this has been formally studied. We here at Mayo, in addition to Qsart, also use the thermoregulatory sweat test. And when we assess a patient with hyperhidrosis, we really focus on the thermoregulatory sweating before a heat stimulus is applied as a measure of hyperhidrosis. You can certainly also look at the baseline of the Qsart recording, which can sometimes give bursts of spontaneous sweat activity and give you a sense of the baseline sweat rate that way. The induced sweat response can be higher in someone with hyperhidrosis than in normal controls, but this is not a consistent finding. And really the normal value creation has very much focused on the lower cutoff and not necessarily on the high cutoff. So I think this is an area that still needs research and further study done. Let's see here. David, if you see anything that I am missing, feel free to let me know.
No, and I'm trying to go over to the chat area and paste them in. So if you see them coming from me, it's coming from the chat side.
Got it. I see a question about medication effects, if they affect the upper more than lower extremity. No, not really. The most classic effect is a generalized suppression. But of course, if a patient has some site-to-site variability, it depends on which site is already on the relatively low end of normal, that will then more likely be suppressed beyond the limit of normal and become falsely abnormal as a result of medication effects, and really it can be upper or lower extremity sites.
So a couple new questions, Dr. Singer. Do you see an indication for Qsart in the workup of POTS patients?
That's a very good question. There is, as many of you will know, the classification of POTS in different subtypes. And the definition of neuropathic POTS has been reduced by findings of a limited autonomic neuropathy, and reduced sweat responses can be an indication of that. However, POTS, as you know, also is very variable in presentation, and there is a number of patients who have reduced sweat responses, but then completely normal cardiovascular adrenergic function. And it is hard to blame a reduced sweat response as a neuropathic substrate if the adrenergic function is normal and should not be contributing to the orthostatic tachycardia. So the answer there is the value is probably rather limited for the workup of POTS. But if you try to differentiate into the different subtypes, it can help or provide some additional information. We perform autonomic reflex testing as a battery, regardless of indication, to keep things standardized, and therefore will include Qsart testing on all patients, including patients with POTS. David, you said there's another one. I didn't see it.
Oh, sorry. Let me. And then value of Qsart for CRIPS or CRPS testing.
We have abandoned autonomic testing for complex solutional pain syndrome. We've been doing it for many years, and we finally looked at all the outcomes, all the data, and the value of autonomic testing for that indication was not very good. not better than the clinician's impression, and we have therefore abandoned using it.
And then the question here on acetylcholine solution seeping out, we've addressed that with Matt on the chat page. So again, follow up with WR, and then if there's further questions, I'm happy to help with that. I did put my email out there for those that have acetylcholine questions. Feel free to send me an email. Did we address the persistent sweat, what that means with Qsart or Qsweat?
I answered that together with the latency. Yeah.
Yeah. Okay. I think we've covered all of them that are in the questions section. We have a gel versus liquid acetylcholine question that just pulled up. That's a matter of preference and what your institution wants to use. When I was developing this with WR Medical, one of the things that we tried to do was eliminate a lot of the leaks that were occurring, especially at the foot site. And we had developed an agarose gel that could be that you could suspend the acetylcholine into and then use that as in the anapheresis process instead of liquid. It's kind of complicated and requires more lab equipment to make those gels. So as far as I know, most people are using the 10% liquid acetylcholine instead of the gel based ones. But either one do provide adequate testing stimulus. One is just a little bit easier to prepare, and one's a little bit easier to work with.
Then it looks like a question has come in about if you see people who sweat before starting ionophoresis and how to control for it. Well, there is sort of this non-specific takeoff of the curve that can occur due to different factors. Some patients have resting sweat activity, and there will be pulsatile excursions from the baseline as you're recording the baseline. And the best strategy there is to let things settle down, wait until you have a reasonable, steady baseline, and then start the stimulus. There can be technical factors. There can be a leak, particularly at the foot side, as was asked before. That can be problematic if you don't have a good seal, and that is usually a rather steep uptake and a high uptake. And it's quite apparent that something unusual is going on at that site, and you'll have to restart. You have to, move to a different site. You may have to slightly move more proximally or distally, or go to the other foot, and then try to get a better technique in sealing the chamber. And sometimes there can be other sort of takeoffs of the baseline that are less clear as to what the underlying cause is. And again, I advise to just wait until you feel comfortable that a steady state has been reached, and then start the stimulation at that time. Because you really just worry about the area under the curve as long as you feel comfortable that the baseline is stable. Just looking back in the chat to see if there's any more.
Yeah, I didn't see any, but I might have missed one. There is one that says, what is a normal value in Qsart for the complex regional pain syndrome? And for the evoked response, that's just what it is. It's the same as Qsart or Qsweat norm values. If you are using those larger resting sweat capsules, we've never looked at the difference between the original data set collected by WR or by Mayo Clinic versus using the capsules collected with the WR equipment. But I would assume because of the same area that those values should be very similar. And I don't know if those have ever been published. Do you, Dr. Singer? The resting sweat values?
And also the resting sweat recording requires a larger volume capsule that was produced for the Mayo pseudometer, but I don't believe is available through WR.
Yeah, it is available.
It is, okay. And then if you want to do it, and I mentioned before that we don't believe there's much value in it, but if you still want to do it for complex regional pain syndrome, obviously the main emphasis is difference from site to site. That's really the only thing we're looking at, is there a significant difference from the affected to the normal site. And if it's bilateral complex regional pain syndrome, then you're out of luck.
And then we have, is forearm location innervation from ulnar nerve?
Presumably so, yes, to the best of our knowledge.
And yeah, I guess Kyle brings up a good point here. For people that are having a lot of problems with the leaks, they do make an electrode that has a foam insert that really helps out when you get a lot of problems at the foot site. So that might be something people might want to look at as well. The question about lifespan of the Qsart machine in hours, I'm going to leave that up to WR as a follow-up question. Our machines we go for a long time. That desiccant is going to depend upon where your location is. So I don't know how to answer in hours. I could tell you in years that we have Qsart machines that are still in operation. So. Regular calibration, yes. We recommend sending the devices in yearly for calibration or recalibration, and just so that the sensors can be recalibrated if need be and recertified to be sure that you're getting the correct sweat responses.
All right, it looks like all the questions are kind of slowing down here, and I don't want to take up too much of your time. You guys have been very gracious, and I appreciate it. So unless anyone else has any last final questions here, I think we're about ready to wrap up. Unless you had any final words. All right. Lifespan and filter. I can follow up with you offline on that, Judy. All right. Thank you both again. If anybody has any additional questions, you can follow up with either us or David or Dr. Singer offline. I'd like to thank everyone else again for joining us, and have a great day.
Thank you.
Thank you.
Thanks.